A very good morning to all of you, and welcome to the CPD program conducted by SHRI, Society for Health Research and Innovation. So, moving on to the few ground rules of the CPD program. Please note that during the CPD program, it is being recorded, and we request you to keep your mics muted and videos switched off for minimal disturbance. And we note that the webinar link will be available from 9 a.m. to 9:50 a.m. for you to join in, and no late attendees will be entertained thereafter. And you should have attended till the end of the webinar to obtain the certificate for the CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. So we request you to have strict adherence on the CPD regulations, and we request your kind compliance during this time. And this is to improve and maintain the standards of the CPD programs conducted by SHRI, the Society for Health Research and Innovation. So a little bit about asking questions. Please note that the question time is at the end of the webinar, and if you have any questions, please type it into the chat function. And make sure that you change your setting to all panelists and attendees so that your questions can be answered. And if you have a very specific question about your situation, please email us on the email address given on screen. So today's topic, we are going to talk a little bit about the parenteral nutrition. And joining with us today is Dr. Dinurangani Jayaweera. She's a consultant nutrition physician from the National Hospital of Kandy. So a little bit about Dr. Jayaweera. She is a clinical nutrition expert who graduated from the Faculty of Medicine, University of Parenteral. She has completed her master's in human nutrition and Doctor of Medicine in clinical nutrition with Merit First and Gold Medal awards. She has further completed her training in clinical nutrition and intestinal failure attached to Edinburgh's Cambridge University Hospital in the United Kingdom. She currently serves as a board-certified consultant in clinical nutrition attached to National Hospital Kandy, and she's also involved in many research activities, academic activities, and community nutrition programs in addition to clinical practice. So now we would like to invite Dr. Evone Dinurangani Jayaweera, the consultant nutrition physician from the National Hospital Kandy, to enlighten us about parenteral nutrition. So over to you, madam.
Thank you. Thank you for the kind introduction. This is the father of intravenous feeding. So the parenteral nutrition is we are giving nutrition through the parenteral route. So the objectives of the lectures are like we need to talk about what is parenteral nutrition actually, when do we use this and how to use this, and then how to calculate parenteral nutrition substrates and the complications, monitoring and updates. So I'm going to explain all of this with the use of a real case history as well. So parenteral nutrition is provision of intravenous macronutrients. Macronutrients is what you call carbohydrate, proteins and lipids, and micronutrients. Micronutrients are vitamins and minerals and trace elements, electrolytes, everything through the parenteral route. The treatment option in patients who cannot maintain adequate enteral nutrition intake. Enteral nutrition intake means oral or tube feeding. If you can't maintain something through the gut, we need to give parenteral nutrition. So commonly used in post-surgical and critically ill patients. So when do we use parenteral nutrition? What are the indications? There are main 3 indications when the gut is not functioning. So in case of perforation, we can't give something to the gut, so it will leak to the peritoneum and cause sepsis, so that we need to use the parenteral route. Then if the gut is obstructed, and if there is ileus, especially post-operative ileus, then inadequate propulsive capacity, if there's no movements in the gut, maybe secondary ileus, then inadequate absorptive capacity. Then if the gut is not accessible due to any anatomical reasons or a lesion like that, maybe a tumor blocking intestinal tract, we need to admit parenteral nutrition for the nutrition purpose until we set access to gut. Then tube feeding is not safe or unlikely to be effective. for example, the ischemic bowel disease, if there's ischemia to the gut, no lack of blood supply, or intractable vomiting, intractable diarrhea. So in that cases also we use parenteral nutrition. So there are several types of parenteral nutrition. We can give total parenteral nutrition. All nutrient needs and fluids are supplied by parenterally. So there are indications for total parenteral nutrition. Then there is a thing called supplementary parenteral nutrition. So combine with enteral nutrition to meet the nutrition gap. So suppose the patient can maintain some amount of nutrition need from the enteral route, but we suspect the patient will not be benefited totally with the enteral route, so we can give a supplementary or a backup plan with the parenteral nutrition. The third one is home parenteral nutrition. So in case of palliative parenteral nutrition, maybe a patient with metastasis to gut, then patient needs last stage of the disease at home, and we need to give parenteral nutrition. Or maybe patients awaiting bowel transplant, not in Sri Lanka, of course. In other countries, they do bowel transplant. Until then, we need to maintain parenteral nutrition so that we go for home parenteral nutrition. Or in case of extreme short bowel, the patient may be dependent on home parenteral nutrition, parenteral needs done at home or community setting. So the patient selection is very important in post-operative patients. Actually, especially supplementary parenteral nutrition. If the gut is totally not working, we need to go for total parenteral nutrition. There is no doubt. But if you're taking, when you're taking as a backup plan for parenteral nutrition, we need really to consider pros and cons and the risk and benefits very carefully, especially in post-surgical patients. If the nutrition requirements are not going to be met at least for about another 7 days, we need to get the backup plan for parenteral nutrition, because otherwise, if you are hurry for parenteral nutrition, it will cause disaster than benefit. So what are the contraindications? If the GI tract is fully functional, and if we can at least get a distal access. For an example, if we say there's a patient with total block of the esophagus by a esophageal cancer. So still we can go for a distal access from a peg, not a peg, actually a open gastrostomy or something like that. The parenteral nutrition is not actually indicated in that case. If parenteral is anticipated less than 5 days without severe malnutrition, that is also another contraindication. So like if the patient is not severely malnutrition, we can give this patient maybe a oral or a tube feeding within 5 days. So in that case, we need not to rush for parenteral nutrition. So if the patient cannot obtain enough venous access, so there are contraindications for venous access, maybe in case of severe systemic fungal infections, etc. So we can't give parenteral nutrition. Then risk of parenteral nutrition exceeds the benefit, and then prognosis is not that good. The patient is in end stage and maybe palliative terminal care, so patient can't eat. So in that case, of course, parenteral nutrition is not indicated. We can manage a patient with sort of 5% dextrose, or maybe electrolyte and hydration only. Then unstable conditions like severe trauma, acute shock, severe metabolic acidosis, those cases, then known hypersensitivity to parenteral nutrition components. So those are the contraindications or checklists that we need to see whether when we try to start parenteral nutrition. So how can we give parenteral nutrition? We give parenteral nutrition through PN catheters. So PN catheters are divided into two categories: central catheters and peripheral catheters. So central catheters, there are short-term one, medium-term one, and long-term one. You have seen short-term one, non-tunnel SVC or these normal CV lines. So we can keep them around 10 days, maximum 14 days. Then medium term ones, not commonly here in Sri Lanka, but PIC lines you may have seen. So peripherally inserted central catheters. Then long term ones you have seen maybe Hickman lines, especially when patients are on chemotherapy. Then Porter cath, those things are long term PN catheters. Then peripheral lines are, of course, we use peripheral cannulas. So these are some of these catheters. So what we give as parenteral nutrition. So these are the macronutrients. Macronutrients, carbohydrate we give as dextrose. So dextrose solutions are available up to 70%. Then amino acids, those are proteins so-called. Then 5%, 10% proteins are there. Then lipid emulsion about 10 to 20%. Then when it comes to lipid emulsions, so in 1960s and 70s, we got only soybean oils, which are polyunsaturated fatty acids. So then second generations, they are MCT and LCT, long chain and medium chain, both mixtures came. Then when it comes to fourth generation, actually the best lipid preparation is MCT, then MCT, soy, fish oil, everything combination. Actually, they give the good benefit. Then types of PN formulas. So when it comes to the first one, multi-bottle system. This is actually commonly used at the moment in Sri Lanka. You can see 3 bottles are hanging: dextrose, amino acids, and lipids. We call dextrose solution, then aminoplasmin, then lipid, intralipid solutions. So this actually we can tailor-make the parenteral solutions. Like we can tailor-make the calorie from dextrose, tailor-make the calorie from amino acids, tailor-make the calorie from lipids according to the need of the patient. But the drawback is we have a lot of ports connecting to the CV line. We have to give all these things through the CV line, this multi-bottle system. So there is high risk of microbial infection due to line handling. So many ports, there are routes for many infections. Then we have to give vitamin, minerals, and trace elements separately. So there should be another port. Then the low cost and the tailor-made pan is the good point of this one. Then the second system is combined system. This is actually used in developed countries very commonly, and we also have some preparation with them under this category. So all nutrients, fluids, electrolyte, vitamins, minerals, and trace elements given combined in a single infusion. So only one port is connected to the patient through a CV line or a peripheral line, so that few line handling and less risk of infection. But we can't tailor-made this. There are set calories and proteins and vitamin minerals, so that we can't tailor-made the nutrient needs according to the patient's need. So these are some of the solutions. Actually, these photos have been taken from this Cambridge intestinal failure unit preparation. So you can see the one of the system Lipomax Peri, that we can give it to the peripheral line. So there are sodium, potassium, calcium included, magnesium, phosphate, zinc, selenium, chloride, everything included, including nitrogen, and glucose and some lipids. So then there are instructions for storage. You have to store in the refrigerator. So these are the all combined preparations that we use as parenteral nutrition. So these are some of other brands that we used in that is used in UK. So you can see the different combinations are there. 1875 ml one, and then 1250 ml one. So different calories, different volume, different micronutrient composition. So there are different solutions available in those developing countries. So according to the need of the patient, actually in this combined system also in those countries, we can tailor-made according to patient's need. Actually, they prepare them inside their hospital pharmacies. So we don't have at the moment, we have only commercially available few preparation in Sri Lanka when it comes to combined system. So yeah, with all this background, we'll go to a small case history. This is one of the patients that we haven't met in our day-to-day clinical practice. So 65 years old female. She was diagnosed to have CA endometrium recurrence after primary surgery with local mets to large bowel and peritoneum. So this is her condition at the moment. She has underwent surgery before. Now she's with the mets to large bowel and peritoneum. Surgery and endoileostomy. So after the first surgery, she's with endoileostomy. There is a pelvic drain in situ. So then CV line in situ. So she's on post-op day 1. So after this recurrence also, she has undergone a surgery. This is after the second surgery. So she has underwent endoileostomy, CV line in situ. She's in post-op day 1. So when it comes to her nutritional assessment, she's with the normal BMI and normal nutritional status. So potassium is 3.3, marginally low. You can see sodium is also marginally low, 133. Magnesium 0.374. It's lower margin. Corrected calcium is normal. Hemoglobin 11.5, no fever, and septic parameters are normal. She's in post-op day 3. Surgeons anticipates 3 days nil by mouth to start clear fluids. Then the surgeons are okay after 3 days when we start clear fluids, and thereafter escalate the oral feeding. How to provide nutrition to these patients? So at this moment, do this patient need parenteral nutrition? So no, this patient at this moment no need of parenteral nutrition. She is in post-op day 1. I have told if we need to start parenteral nutrition in a specially nutritional normal patient, if oral intake or enteral feed is anticipated within next 5 days, we don't need to rush for parenteral nutrition. So in these 3 days, we can manage this patient with balanced crystalloid like normal saline 5% dextrose with fluid management, maybe correction of potassium, stat correction or maintenance dose of calcium or potassium, whatever, and monitoring and replacement of phosphate, magnesium, input-output chart, then gastric ulcer prophylaxis and everything. So when we are managing this patient like this, post day 2, could start oral clear fluids quite early than a surgeon expected. Then could start oral clear fluids with protein. Then we escalate the clear fluids with added protein powder. So nutritionally, that is how they are managed. Then post-op day 3, she developed bilious vomiting and abdominal distension. So what could be the cause? Maybe post-op ileus, simple post-op ileus. So electrolytes were normal, so low potassium can give rise to ileus. So we went through the electrolyte, they were normal, blood sugars were normal. If the blood sugars are not maintained, there can be gastroparesis and all. So blood sugars were normal, there were no issues with that. Then bowel sounds were scanty, stoma was not working with anemia, so that there can be element of ileus or functional ileus, or she's anyway with secondary meds, maybe gain obstruction with meds or surgical adhesion or whatever. Septic parameters were normal, bowel obstruction was suspected, so NG free drain was inserted. So what we do in these cases, we do the x-rays and we put NG free drains. How do we provide nutrition to this patient now? Now post-op day 3 with the bilious vomiting. So in this case, the parenteral nutrition is indicated. So not in day 2, but in this case, I hope you understand my point. So now she's with the bowel obstruction, that we can't anticipate, it's bilious vomiting, we can't anticipate to start a oral nutrition in about another, at least for about another 2 to 3 days. So even though she's nutritionally normal, we need to intervene with the parenteral nutrition. So we gave parenteral nutrition through CV line, tailor-made multi-bottle system, system. Because it is usually commonly available in our system, our setting. So how did we calculate? So this is how we calculate 65 years old lady, body weight 50 kilos. So energy, we don't need to over feed this type of patient. This is her normal energy requirement. We can see energy 20 to 25 kilocal per kg per day body weight. So that at least 1000 to 1250 kilocalories per day is needed for her. Then 50% from carbohydrate calorie. That is how you usually normally take for oral nutrition as well. So that 50% means, so we calculated first protein down, you can see the down. The protein we get usually post-surgical, so her creatinine was normal, so and also her catabolism is high. So we need to preserve muscle, so that we give more than higher requirement. Normal protein requirement is 0.8 grams per kg per day, but in here we need to target, even though the calorie low, but the protein should be high, 1.3 grams per kg per day. So the protein should be 65 grams per day at least. So we give from 10% amino acids, so that we need to give 650 ml per day amino acids divided by 24 hours. It will come around 20 cc per hour or something like that. That is 10% amino acids. So one is finished. Then we went to protein. In parenteral nutrition calculation, we latter part, finally we go for the dextrose part, because we can reduce or increase the concentration of dextrose. So that first we calculate the protein and take the volume for protein first, then for lipid. So lipid calories we went for 30%, and it comes as 41 grams of lipid. Intralipid we have only 10%. We don't have 20% here at the moment. In Sri Lanka we don't have any product of lipid. There's a shortage. So those days we had 10% lipofundin, hopefully. So from 10% lipofundin we gave 416 ml per day. So 416 ml plus 650 ml, it comes around 1200 ml of daylight. So then we have to discuss with the surgical team what is total volume that they allowed for this patient. Of course, with the drainage and losses and all, she will need quite a good big amount with insensible losses, drainage loss, and the third space losses, everything. So around 2,500 to 3,000. So that of course we have a lot of fluid requirement for parenteral fluid available for parenteral nutrition. So still we went for 50% dextrose, because we have the CV line and there were no issues with the sugar control. So we gave from 50% dextrose 368 ml. And in this case, of course, we could have gone with 25% or 37.5% dextrose concentration also, because we had enough volume. I hope that you understood what I said. So when you give parenteral nutrition, you have to consider the total available fluid for the patient as well. So in these type of patients with the losses, we need to supplement more. So even if you deduct fluid that is used for drug administration and other things, in this type of patient, we have a good amount of fluid allowance for parenteral nutrition. So we could have gone, if there were issues, if there have been issues with glucose control or any sepsis or anything, we could have gone for lower concentration of dextrose as well, because we had more volume. Then the next step, so I hope that you understood how I calculated the parenteral nutrition. So the calculation, so fluid was there for 35 ml per kg per day, 1750 plus the losses from the NG drain and peritoneal drain. So we replace it with balanced crystalloid. Then so we supplemented carbohydrate, dextrose and parenteral from the previous slide. Now I have shown you how did we give other elements of nutrition, maybe electrolyte and vitamins and minerals. So electrolyte, of course, potassium 1 to 2 millimoles per kg per day, 70 millimoles. Then sodium 2 millimoles per kg per day. So especially from the free NG drain, if you lose 1000 ml, you need to supplement 100 millimoles of sodium, because sodium losses are more with the jejunal and gastric content. Then magnesium 0.2 grams per kg per day. Then it comes as 10 millimoles per kg, 10 millimoles per day. Then calcium 0.2, then phosphate 0.3 millimoles per kg per day. So the prescription of this patient was 50% for 24 hours. This was the prescription. So other balance fluid requirement, everything provided as needed according to these calculations. So then coming to other things, combined system. I told you about combined system. I showed some pictures of combined system, the combined parenteral nutrition. So for this patient, actually, we gave multi-bottle system. Separately, we gave from 3 ports from the CV line. But now I'm showing you what are the products that we could have used this patient if you have combined system. In Sri Lanka, we have these products. We can give these products to peripheral line. You can see amino acids or the protein content is very low in these products. So, and the osmolality is maintaining 750 to 800, which we can give, which is so that we can give through peripheral line, even peripheral cannula. So these products, actually, I can't give you the product's name. You may have seen these bags. So soy, you can see these products, of course, made of lipid particles, are made up of mainly soy oil. So which are older generation lipids, so which are not that good in terms of lipid molecule. And also you can see lipid content of this lipid calories, or the lipid content of the products are very high, because they maintain this low osmolality by adding more calories from the lipid. The amino acids are the thing that increase the osmolality of the solution, so that they have reduced the protein content and increased the amino acid solution. So that rather than giving these products, if you can maintain very good infection control system, giving multi-bottle system in that case is good rather than giving this product. But in case of lack of access to CV line and lack of products available and those things, and if we need to give peripheral parenteral nutrition, I will talk it later. What are the indications for peripheral parenteral nutrition? We need to use this product. So now for that patient, we gave carbohydrate, dextrose, amino acids, lipids, and also potassium, magnesium, and everything calculated. Then there's a lacking part for nutrition, micronutrients and minerals. So these are the micronutrients and essential minerals we need to have in our system, in our body. But unfortunately, rather than B1 and polybione, we don't have parenteral multivitamin or mineral things in our setting in Sri Lanka. So, in fact, for needed long-term parenteral dependent patients, once or twice I have bought it from one of the other countries. Of course, when I gave the prescription, the relatives bought and gave only one time. Otherwise, even in private sector, we don't have parenteral multivitamin solutions in Sri Lanka. So the case history. Now the patient is on parenteral nutrition, multi-bottle system. We give separately dextrose, amino acids, and electrolyte. So then full calorie and protein with parenteral within 2 days while monitoring for refeeding syndrome. So then full calorie and protein was given. NG trend reducing output. Then we are monitoring her as well clinically. NG trend reducing output, the color going to be good, like maybe less bilious colors and no vomiting. Then we clamped NG and so observed there was no vomiting, and stoma also started to work with enema. Bowel sound appeared. So there has been a short-term ileus post-op. She developed hunger cues also, which is a good point for that her gut is working. So then we again started oral clear fluids and advanced to thin liquid slowly while PN support continues. We gradually do do not stop parenteral nutrition support even if we see good signs of gut working. We backup as a backup plan. We continue the parenteral nutrition, and then we monitored and give small amount of clear fluids and at a bit of advance, like maybe to isosmotic therapeutic formula, oral formula, like that. Then drain output started yellowish and thicken and increase when advancing oral liquids. Again, when you go for oral liquids, it is getting problems. So then she developed fever and septic parameters were increasing. Blood culture remained negative. CECT, extensive peritoneal mets. Then we did CECT because of this continuous bowel thing. Extensive peritoneal mets and suspected fistula connecting bowel and pelvis. Then fistula connecting bowel and pelvis. How do we provide nutrition to this patient? So there's an infected fistula now. Bowel is not working. So we need to, if there's a fistula and bowel is not working, there's no doubt fistula is also infected. So if you give more gut feeding, the fistula is going to be more infected and it is connected to the peritoneum, and she will develop definitely peritonitis and sepsis. So that we have to stop we have to keep her nil by mouth, no doubt. From that side. So then we have to focus on nutrition. So focused on parenteral nutrition continuation, anticipated to continue 3 to 4 weeks. So that we have to continue this parenteral nutrition. She is parenteral dependent for 3 to 4 weeks. Can we continue PN here when septic parameters are high? Yes. Blood culture negative. We know the focus, then it is from the peritoneum and the septic foci. And nutrition also important to have this one, because we need to heal the fistula, and also for 3 to 4 weeks we need to maintain her nutrition. Of these we need to continue parenteral nutrition. Why I ask this parenteral nutrition is safe in terms of high septic parameters, because when you have, if in this case blood culture positive, I'll talk later, or if there's a disseminated infection in blood, if you give nutrition parenterally, the bugs can get the nutrition and grow fast. So that is the case why I'm asking, is the parenteral nutrition safe here? Still yes, because the blood cultures are negative, and considering all the other clinical parameters, she is indicated for parenteral nutrition, and we continued the parenteral nutrition through the CV line for 3 to 4 weeks. But omitted lipofundin at the peak of the infection as it contains pro-inflammatory agents. So I told, like as I showed you earlier also, in our peripheral parenteral nutrition solutions also, we have soybean preparations which are older generation and pro-inflammatory kind of thing. So in this case, we omitted this lipid parenteral lipid component because it has pro-inflammatory effect. And also, lipid is actually not necessarily to give long run. We can give as bouts, like once a week, maybe like that. So by monitoring when septic parameters are stable, lipofundin added and removed, like that, lipofundin was adjusted, but the protein and dextrose calories were continued. With all these things, we come to the complications of parenteral nutrition. So you have already learned there is a complication like line associated bloodstream infection. We called it CRBSI, catheter related bloodstream infection and local infection. So when we give parenteral nutrition through especially CV lines and maybe peripheral line also, these are nutrients, and if there are bugs in the, especially in the bloodstream, that's why I specifically told blood culture negative. In that case, the bugs can get nutrients and grow fast. So, and also they can colonize the CV line as well. And CV line is not a joke, of course. It's connected to the heart, so they can cause endocarditis and also lots of complications, emboli, and also this is the major complication of long-term parenteral nutrition if you do not adhere to safety measures, and also if you use parenteral nutrition in unwanted setting. So that's why I'm always saying parenteral nutrition selection is very important, and it should be continuously reviewed whether the indication remains same or we can use gut. So in that case, in this in this case also, you have seen I have day by day reviewed the condition, oral condition, what's the drain output, whether we can have a hope for oral or enteral access. If there's no hope, of course, we need to continue TPN because in this case it was a fistula. But otherwise, we need always to review the indication, whether it is really indicated, like that. Then infective is one of the complications. Then the other complication is metabolic complications. Of course, we are giving dextrose solutions where they can get hyperglycemia and rebound hypoglycemia. When we off the parenteral nutrition, we can get hypoglycemia. Then hypertriglyceridemia, that is a known complication. Then liver steatosis and cholestasis. Then liver disease and metabolic bone disease if they are on long-term parenteral nutrition. These complications, long-term complications, are seen especially in bowel transplant awaiting patients and short bowel patients who are really dependent on parenteral nutrition, not these type of patients with short-term fistulas and all. Okay, the other complication is refeeding syndrome. So you have heard refeeding syndrome. Of course, refeeding syndrome is common to enteral feeding and parenteral both. It is a potential fatal shift of fluids and electrolytes that may occur in malnourished patient receiving artificial refeeding. So when the patient is not fed for a long time, if the patient is malnourished, there are criteria for actually nice criteria to diagnose refeeding syndrome and to assess the risk of refeeding syndrome, especially even if the patient is not fed. Yeah, if the patient, even if the patient is not fed for long run, but even if the patient is fed well, but if the patient is a cancer patient on chemotherapy, insulin, and low levels of magnesium, potassium, and all, patients still are risk of refeeding syndrome. There is a myth that refeeding syndrome cannot be occurred in patients who are fed well. That is wrong. If you go to NICE criteria, I don't have time to explain everything. NICE criteria, there are major criteria and minor criteria. Sometimes even our clinical practice, our doctors, they have exclude refeeding syndrome with the fact that the patient has fed well up to yesterday. No, that is only a one criteria. There are so many other criteria. Patient can be still risk for refeeding syndrome with several other criteria, even if the patient fed well up to the point. Okay, the hallmark of this biochemical feature is hypophosphatemia. So then, hypophosphatemia and hypocalcemia, hypomagnesemia, hypokalemia, and sodium can be hyper or hypo. So then we have to manage refeeding syndrome accordingly. So first 1 to 3 days, low calorie and low fluid volume, and also we have to supplement, especially thiamine in high dose, and 100% required daily intake of mineral and trace elements, and replace especially phosphate and other electrolytes, and slowly increase the calories and fluids like this, as you can see in this chart. So refeeding syndrome is another complication of parenteral nutrition. Okay, so monitoring of parenteral nutrition. So that as you have seen with the case, we have monitored daily electrolyte, clinical and metabolic parameters, sugar, electrolyte, glucose, and the clinical status. And also nutritional monitoring is also needed, whether we have to, when the patient is on parenteral nutrition, whether the patient is on adequate nutrients and whether it is reaching goal, and whether there is still signs of malnutrition, and the patient is gaining weight or weight stable or like that. Okay, case history continued. Now the patient is with fistula. We are continuing parenteral nutrition through the CV line, multi-bottle system, that is separate the glucose, dextrose, and lipofundin on and off according to the maybe CRP, fever spikes and all. There was peritonitis, infected element of peritonitis, infected fistula, but blood culture was negative so far. So then what happens? Blood culture becomes positive for enterococcine, 4th week of PN. We have successfully continued for up to 4th week of PN, allowing fistula to heal. Then septic parameters increase and clinically not well. So blood culture positive. Now the patient's clinical condition, we are continuing parenteral nutrition through the CV line, blood culture positive, and for enterococci. Then clinically not well, septic parameters are increased. Then PN withheld and started antibiotics according to the microbiology opinion. CV line cultures were negative. So we usually do paired cultures as well. CV line cultures negative. So repeat blood culture 74 hours. Then we usually do repeat blood cultures after the antibiotic started. Then after the antibiotic started, 72 hours blood culture was negative. Then CV line culture was negative, so that there were other indications. So maybe we can give CV line. We can give antibiotic through CV line better, and potassium we need to give potassium supplementation we can give through the CV line, and also calcium, because sometimes through the peripheral line they are irritating. So since the CV line culture was negative and repeated blood culture was also negative, we kept the CV line in situ. It was kept in situ, but for the parenteral nutrition, we established peripheral parenteral nutrition, because rather than giving, even though uninfected CV line, rather than giving directly to the near to the heart, we thought of giving peripheral compatible parenteral nutrition with the solutions that I showed earlier, that is combined system. So they can be given through peripheral route. So through the normal cannula, we gave parenteral nutrition. Then regarding catheter-related bloodstream infection, so British recommendation or the definition is isolation of the same organism from the catheter hub and the peripheral vein. Differential time for positive more than 2 hours, threefold more colony count from the central line. So 2 hours gap and the same organism should be positive through the line and as well as peripheral blood culture. So if that case, we consider it as a definitive catheter-related bloodstream infection. In that case, if the CV line is a fresh one, and if the patient doesn't have any other CV line access, if the patient needs CV line for other purposes, we can do antibiotic line lock through with vancomycin, or if the patient can have other access, or if the patient doesn't need CV line, we can remove the CV line and set line free, infected line and line free. Then probable CRBSI is pyrexia and rhigos with PN with positive peripheral cultures and no other source of infection. So if the patient develops pyrexia with rhigos, possibly within few hours after starting a parenteral nutrition, without other source of infection, we suspect probable catheter-related bloodstream infection. In that case, we have to withhold the parenteral nutrition. So, how to prevent this catheter-related bloodstream infection? Use single lumen catheters. That is one thing. Rather than giving multi-bottle, most of the time to use one time if we can use. Then dedicated line for PN. So, especially even if you use peripheral cannula to parenteral nutrition, do not use so don't use that even peripheral cannulas or even major CV lines. Keep the dedicated line for parenteral nutrition. Don't use other things don't give other things through that port. You can give, of course, antibiotics through that port if it is really necessary, because we don't have many ports in such a complex patient, but don't use for other fluids and electrolyte supplements and any other things. Then appropriate insertion site and using USS catheter for catheter insertion, appropriate insertion site, especially to avoid femoral catheters for parenteral nutrition is a must. Then adhere to central venous catheter care bundle. Central venous catheter care bundle is another set of thing. Actually, when you give, especially now this combined system, I will say the most common brand that you have heard, Evone or something. Like if you give Evone, you have to connect it at once and disconnect at once per day. So like you can't connect it, and then if the patient is going to the scan or something, you can't disconnect. You cannot disconnect and hang around the ward. I have seen many wards that Evone is used in that in Evone or TNA peri that we are using in Sri Lanka is used in that especially in wards. Like you connect it, and then when the patient goes to toilet, and you disconnect it and then reconnect it. So lot of connection and deconnection. And also I have seen nurses maybe without knowledge, they connect and disconnect even without a gloves. Actually this should be done as a very sterile procedure, connection and disconnection, and you have to rub the hub for 15 seconds. For this line care, we have I also did several lectures, and we have did several workshops with the College of Microbiologists. This is a must actually. Line care bundle, adhere to line care bundle is must. Especially like you guys will think like how could then the patient be taken to scans and everything when the patient is giving Evone or TNA peri. So it's like that. We have several options. So you can contact always a nutrition team. We nutrition team, like we set this parenteral nutrition rather than 24 hours or 20 hours. We when I put that, when I or my team put that, we set it for night time. So then patient can do everything in the daytime, toileting, washing and everything, and take the parenteral nutrition during the evening and the night time. So night time the patient is usually immobilized, and then we can prevent. And especially with my experience, especially when we give the patient parenteral nutrition to ulcerative colitis or Crohn's patients, so they are having increased bowel motions even in the night time. So and toileting. So when they are they are having malnutrition and also malabsorption, also there are a lot of instances that we need to give parenteral nutrition backup. In that cases, we have put catheters to patients to keep immobilized to prevent this catheter-related bloodstream infection, and also then set the time for especially night time, and to take the parenteral nutrition bag covered, the insertion tied to the toilet and coming back safely from the toilet. So that those are the things that we can take rather than disconnecting and connecting every time when the patient is mobilized for any procedures or any toilet purposes or anything. So the case history again, this is the last part. This is last, and actually I'm going to give you a most complex situation that we can encounter in case of long-term parenteral nutrition patients, fistula and bowel obstruction. Actually this is a real case that we encountered. So now the patient is on peripheral parenteral nutrition because the blood culture was positive, and but the CV line culture was negative, and she was on antibiotics. And so while on peripheral parenteral nutrition, she was doing well, and drain output became nil, and septic parameters improved, managed to continue another 1 week of parenteral nutrition. So now this is the 5th week of parenteral nutrition. Very high fever with chills and rigors. Now, when it comes to fistulas, these kind of fistula, at least we need to keep these patients nil by mouth for about at least 6 weeks to completely heal the fistula. In this case, this type of patients, the fistula healing can again be delayed because of the background condition of this patient, cancer and the disease, gut, everything. So septic param. So again, in the 5th week of parenteral nutrition, the patient again got high fever spikes with chills and rigors. Septic parameters increase. Then PN withheld because we know this can be probable CRBSI, probable line infection. Also, then septic screening done, including paired line cultures, blood cultures and CV line became positive for yeast. So this yeast is a fungus. So then antifungal started. So how do we provide nutrition to this patient now? So Ecodon. So in case of fungal infection, the high risk of endocarditis, so vegetation, so Ecodon. Discussions were made whether to remove this line. Patient has difficult access as well. Repeat cultures negative but still septic. CV line removed, still gut cannot be used, still gut is blocked, and also there is a fistula. So CV line is removed because when the blood culture positive for yeast, and yeast and the patient is dependent on parenteral nutrition, and especially patient has difficult CV line access. In this case, even in developed countries, they get a MDT, whether to remove the line or not. So in this case, after the MDT discussion, CV line was removed because more you have the line, even though the repeated cultures positive in case of yeast, there is risk of colonization in case of especially in background of yeast or fungal infection. Not like other infection, fungal infection are when infections are very dangerous. Even so, at least the recommendation is, especially in case of fungal, even if the patient is not even other if the other backgrounds are safe, like maybe the patient is not on parenteral nutrition, or the patient doesn't have difficult IV access, the straightforward decision is to remove the line or remove the all plastics from the body, lines, even peripheral lines, for about 10 days to 10 days after completing 10 days until completing antifungals. But in this case, we need a discussion, we need all opinion whether to remove or keep the line. So the line was removed after discussion. So how do we provide nutrition to this patient now? It's very challenging. We have two options. Fungi can form biofilms with plastics and materials. So repeat negative cultures is not a license to start parenteral nutrition. That's why I told, not like in bacterial infection. In bacterial infection, of course, if the repeat blood cultures are negative, we can insert another line and then give parenteral nutrition through that line. So that is for other infections. So as I told, most of the trusts in UK, they stop PN and all plastics free interval for about at least 10 days, and they complete fungal infection. And they, even though the patient is dependent on parenteral nutrition, they try maybe other options like fistula crisis, so like you get the fistula fluid and then reinfuse the fistula fluid to the gut. So that maybe that sophisticated methods, like with the pumps and all, we don't have those pumps many frequently here, or else they keep the patient with only maybe normal saline or 5% dextrose with the peripheral line. The option 2, if the patient is malnourished and septic parameters coming down, peripheral parenteral nutrition again can be considered in these kind of patients. So we went for, I think, option 2 in this case. So the case history summary: we had normal nutrition patients, status post-op, no need of nutrition in post-op day 1 because the patient anticipated to have oral nutrition in 3 days. Then day 3 we had bowel obstruction. So even though the patient was normal nutritional status, we anticipate later of starting oral nutrition. So that is the indicator that we started parenteral nutrition here. Then bowel obstruction improved. So as you can see, we always review the chance of enteral nutrition because PN is always a risky form of nutrition. So then we try to advance oral nutrition, but there was a fistula. Then we kept patient nil by mouth and TPN for parenteral nutrition, TPN for 4 weeks. So infected fistula and blocked gut is a definite indication. So that's why we continued for 4 weeks. Then gram-negative sepsis, no line sepsis. Then PN short-term withhold and restart parenteral nutrition when the peripheral culture was negative after antibiotic. Then fungal infection, PN held, line removed. Then nutrition we gave via peripheral line for this patient until we get stabilized with the gut access. At least we got this infected fistula to some extent lower output. So way forward, so I think you have understood the implications with the case history, also the risk of PN parenteral nutrition, and how the care should be done. So we need more, according to my experience in clinical setting, we need more and more line care workshops for healthcare, more knowledge and users and indication workshops for about parenteral nutrition, because it's not just a saline or anything. Even we can give parenteral route. It should be a tailor-made and also a very it's a risky form of nutrition. If we go wrong, it can cause more hazard than benefit. I think that's all. Thank you, and open for questions.
Thank you so much for that very elaborative lecture, Dr. Evone Jayaweera. So we have received, we reached the participants limit of 500 in this lecture, and we have received more than 200 questions regarding your lecture. So so many of them have been covered in your lecture, mostly about how to initiate parenteral nutrition, on calculations, and also about the complications. We discuss more elaboratively on it. So a few questions which I would like to draw your attention is, one of them have asked whether there are any contraindications in giving parenteral nutrition to patients. So it's one of the
there are many contraindications, like of course with severe metabolic acidosis and severe unstable clinical conditions, like especially in ICU patients with MAP less than 60, we don't start, and we stabilize the patient, and then we go for nutrition. And then as I told, severe fluid overload. And as I told you, like if there's line access is not that not it's query, and also those are the contraindications, of course. Like it's also dependent, and also in case of line infection, so there are instances that we need to see whether it is indicated really or is contraindicated. So it's maybe patient to patient dependent.
Exactly. And then another question which we ask in the chat function is that what is the benefit and complication in comparison of CV line to peripheral line when giving parenteral nutrition?
Yeah, perfect. From that, that's why I wanted to highlight from my story as well with my patient. So initially, as you all can see, I gave parenteral nutrition through CV line. And but later, when I saw the line infection, not line infection, there's a focus of infection, blood culture positive. So the CV line, blood culture was positive, and in that case, the patient needed, of course, parenteral nutrition. There's no doubt. So that we need to give some nutrition, but rather than using CV line, in that case, parenteral nutrition from peripheral line was beneficial for this patient, because we are not accessing the gut. We are not accessing the heart, accessing these nutrients closer to heart. So the risk of parenteral nutrition on top of positive bloodstream infection, is the bugs can get the nutrients and grow. And if you give through the CV line, in that case, like the bugs can easily, there are valves in the heart, so that, but it's closer to heart, so that if you give through the see, whether it's from my end or possibly, yes, that is the thing. Peripheral line, of course, again, even though when you're giving peripheral line or CV line, the risk of infection is risk of infection and aggravating infection is less in peripheral line. But the line care, I need to elaborate that our line care should be same as strict in CV line care and peripheral line as well in case of handling parenteral nutrition.
Okay, madam. Another question which was posed, actually two questions. Please give
Yeah.
advice on a poor man's parenteral nutrition that we can try in ward in cancer patients in relation to mostly on lipids and proteins, and also the ethical consideration when denying parenteral nutrition in terminal patients. So because in Sri Lankan culture, yeah.
Poor man's parenteral nutrition in cancer patients.
Yes, madam.
What is the question? Sorry.
Yes, madam. So they have
asking.
asked, please give advice on a poor man's parenteral nutrition that we can try in ward in cancer patients in relation to lipids and proteins, because I think considering the high cost in these nutrition therapies.
Yeah. Actually, for cancer patients, again, the first thing is when you give parenteral nutrition, we need to see whether it is really indicated. So then, usually I have seen in oncology wards, mostly they start parenteral nutrition because patient kanda marui like that. That is not an indication, of course. If my team or we see whether we can get, there are hierarchy of nutrition provision. First thing is oral nutrition, then we can modify nutrition, the fortified nutrition. Then the second thing is oral nutrition supplements. So maybe we can give through sip feeds, maybe spoon feeds high calorie formula, which can give more calories and proteins than parenteral nutrition, more benefit than parenteral nutrition. So that is a third step. Then the fourth step is whether we can insert a small NG or something like that. Then failing which, we go to the parenteral nutrition, so that for most of the cancer patient, of course, we can manage something better without parenteral nutrition with other options. That is the first thing. So if the cancer patients like this patient, like have fistula, or patients with severe mucositis, severe diarrhea after chemotherapy, some patients get severe mucositis, severe diarrhea, and especially after radiotherapy, CV line, we can go with, or maybe for a short term they improve.
Madam, there seemed to be a small technical issue in your side. We couldn't hear the last part of your explanation.
Depending on the patient, we can give both actually. The poor man, like in the hospital setting, we have some preparations, peripheral and also multibottle system. And ethical consideration, delaying parenteral nutrition is actually delaying any nutrition is non-ethical. So if the patient is indicated for parenteral nutrition, we need to start weighing the risk and benefit. It's not ethical to delay.
Yes, ma'am. And another question, can we give multiple bottle parenteral nutrition through a peripheral line?
No, no, of course, no, because more than 12.5% dextrose we have to give through central line. Then 10% amino acid, of course, we need to give through central line. But lipid we can give. As I told, lipid is the 10% lipid we can, of course, give through peripheral line, because lipid is the lowest molarity solution. So there were some instances when we work in these settings, like in hospital setting, general hospital setting, there were some periods that I did not have these multi-bottle peripheral parenteral solutions like TNA and Cabevan, as you all know, and the patients doesn't have ISCV line access. So in that cases, I have given with cautious two-way cannula and flush the 10% amino acids with 12.5 dextrose. So in that case, with close monitoring and excluding the thrombotic risk and getting a big risk to a big peripheral line, I have given in that cases, because patient need and we have to do something with the available resources.
Yes, madam. Thank you. And one last question, madam. With enteral nutrition, can we give parenteral amino acids to supplement the feeds?
Yes, we can supplement the feeds, but supplementary amino acids, hospital setting, we have only this 10% amino acid. But in private sector, we have some compounds that can be given, some protein compounds that can be given peripheral line. So in patients with especially these albumin cases, low albumin and low protein intake and all, I would top up with this peripheral parenteral amino acid solutions.
And one final question to finish it up, madam.
Okay.
They have been asking whether the same formulas could be given in the pediatric population as well, or whether there are any different formulas available.
Yeah, I'm coming across very many pediatric patients with neck and perforation, and a lot of patients we have. So we don't have pediatric compatible formulas that I have been using in UK. So what I give, we make them compatible with parenteral pediatric solutions, especially for pediatric patients. Amino acids we need to give Vaminolac, so which is not available at the moment. So for these days, I have compared the Vaminolax preparation with 10% amino acid solution, and especially the Celamine brand, which is usually available in most of the hospitals. So instead of Vaminolac, I have given Celamine brand 10% amino acid, and dextrose, of course, yes, we can give same. Then lipids, we don't have any solution. So actually for pediatric population, especially neonates, when they are having neck and perforation and all, and we have babies that are dependent on parenteral nutrition for about 2 or 3 weeks, in that case, they will really develop essential fatty acid deficiency. So what I do is, I don't have any parenteral with population, even in private sector, even the patients are affordable to get them. So what I do is the skin. So there are very lot of shortages of parenteral nutrition solutions, especially in terms of pediatric and neonatal populations. And when we use these bottles for small babies, there is a wastage also of the products, because they come in 500 bottles. Then you have to use only 10 ml or 20 ml. So we have to discuss, and also we can't use them after 24 hours. That is also another thing. I have seen parenteral nutrition solutions are hanging around 2 to 3 days. So don't use that. This hang time is only 24 hours. You can use it only 24 hours. Remaining parts, please discard. So that is the thing. That is the manufacturer details.
And thank you so much, madam.
Yeah.
I'm sure we have learned a lot through your presentation today. And so we have got so many questions also to be answered on the presentation. So we would like to thank Dr. Evone Dinurangani Jayaweera, the consultant nutrition physician from the National Hospital Kandy, especially for your very valuable time and sharing your information and your knowledge with us during this presentation. And we on behalf of SHRI, the Society for Health Research and Innovation, we sincerely thank you for your precious time, and we really hope that you would join with us in future also in so many interesting lectures to improve the knowledge of our doctors. And finally,
thank you so much
a little bit on information for the doctors who have joined in. So you will find the link in today for the CPD points. And if you want, please give your kind feedback to us through the SHRI on the SHRI email, or you can either post it on the chat box. And please answer the post-assessment questions which are posted in through the link, and then you will receive your e-certificate for participation in the due course. So thank you so much for joining with us today, and especially to Dr. Evone Jayaweera, and also for the participants who have been joining with us today. So thank you so much, and we wish you all a very good day.
And thank you for listening. Thank you very much for inviting me. Thank you.